safe and healthy, all of you who is listening to us from home, and welcome to this webinar series that's sponsored and led by the Saudi Society of Blood and Marrow Transplantation. This session of tonight will be sponsored by Takeda company. I'm honored to have with me tonight Dr. Ihab Al-Hamidi, who's a consultant hematology bone marrow transplantation at Princess Noura Oncology Cancer Center in King Abdulaziz Medical City in Jeddah. Dr. Ihab is an associate professor of medicine in King Saud University of Health Sciences in Jeddah. He's a dear colleague and friend, as well as a mentor to all of us in the Western region, and a model that many of us would follow. Dr. Ihab will be talking to us today about real-world effectiveness data for multiple myeloma management. It's a real interesting time for multiple myeloma, with many new therapies being approved and added, with new combinations are always in the pot being cooked. The effectiveness data varies from one therapy to the other, from one combination to the other. And most importantly, the reflection of this on our patients really depend on the type of patient that we are dealing with, and thus affecting the expected results in such a patient. Without any further delay, Dr. Ihab, welcome, and the Zoom is all yours.
Thank you, Dr. Absi, for this kind introduction. And I would like to start my talk about real-world effectiveness data for multiple myeloma management by letting the audience know what I'm going to discuss today. So what I will discuss today, what is the role of real-world data in the management of myeloma, and I'll try and convince you that it is something that is worthwhile investigating and having some knowledge about. I will give some examples of differences between real-world evidence and data versus clinical trial data, and I will talk about patient choice and give an example, and about frail patients management and renal impairment patient management, and then I will conclude my talk. So real-world evidence or data is basically based on efficacy versus effectiveness. So efficacy is what clinical trials give us as an outcome, while effectiveness is what real-world data or evidence give us. Efficacy is defined as the ability to produce a desired or intended result. Usually it is as a result of performance of ideal controlled conditions, which we find in phase 3 trials, primary efficacy endpoints that are defined before the trial starts. And there are some usually secondary endpoints, and it investigates safety, tolerability, and patient-reported outcomes. While effectiveness is a more broad term, it's about the performance of a regimen under real-world conditions in the real world. So it has an impact. It's different from efficacy because phase 3 trials usually are done under a more motivating environment than real-world conditions. So where do we get the real-world evidence from? The real-world evidence, we tend to get it from multiple sources, local, national, clinical registries, electronic health and medical records, in the state's billing and insurance claim database. There are some observational non-interventional studies and some cross-sectional prospective data. So it's multiple sources that end up giving us the real-world data. So in multiple myeloma especially, there is a reason why we should actually have real-world evidence. It's because 40 to 50% of myeloma patients are actually fit to enter a clinical trial. So half of the myeloma patients actually are not fit to enter a myeloma trial. So that's a big proportion of the myeloma patients would not be eligible to enter a trial, as we will see. Patients who are ineligible for inclusion have poorer survival and prognosis, and thus the clinical trials data that we tend to see and depend on in our managing of our myeloma patients poorly represent the majority of real patients of myeloma that we see in the clinic day in and day out. So this slide shows a series of publications that were made looking at real-world data of myeloma patients. And you can see here this list, and you can see here the ineligible patients in each study. This first study is saying that 40 to 56% of patients were ineligible to enter a myeloma trial. This one here is saying 22%. This one is 47 to 72% of patients were ineligible to enter trials. So between 20 to 70% are unfit for myeloma clinical trial, which is going to have an impact on our treatment decisions and patient in front of us in the clinic. I will give an example with one study just to give you a flavor of what these studies do and what do they show. This is an analysis of a common eligibility criteria for randomized controlled trial in newly diagnosed myeloma patients and exploring outcomes. So this was taken from a Connect Multiple Myeloma Registry, which is a US-based multi-center prospective observational cohort registry. The study aimed to look at the demographics and clinical characteristics and management and outcomes of newly diagnosed patients treated in the US community and academic institution-based oncology centers. Enrolled patients are more representative of the general population, as you'd expect, than a clinical trial. So in this study, all those patients who were enrolled in this registry, which were 1,406 patients, 40% were identified as ineligible for clinical trials by what the usual trial criteria are. If one uses strict criteria, clinical criteria, then 56% will be ineligible. Usually cancer patients, only 5% of cancer patients participate in clinical trials overall. So what are the barriers for enrolling patients into clinical trials? The barriers are usually patient-specific. Patients might lack interest or information or concern, and there's some myth, and they don't want to participate in a trial. Protocol-specific problems, eligibility criteria, time, demands, availability. And then there is physician-specific biases. Some physicians do not want certain patients to participate, and they won't invite them to participate in a clinical trial because of some concerns. What we will discuss today is protocol-specific eligibility criteria. So this study is mainly about protocol-specific eligibility criteria problems. So we are not, or real-world data will not look into patient-specific and physician-specific criteria. In this study, the most common randomized controlled trial exclusion criteria were found to be 39, and they chose 24 out of the 39 exclusion criteria to apply on these 1,400 patients of myeloma. The commonest exclusion criteria were absence of measurable disease, peripheral neuropathy of more than 2, ECOG of 3 or 4, history of dysplasia of hematologic malignancy, renal impairment. So you see here in this table the criteria by which the patients were excluded from the trial. And you can see here, because 25% of patients had a paraprotein of less than 1 gram per deciliter in this group. So this, in many trials, was exclude the patients from enrolling into a clinical trial. Another exclusion criteria, some patients had a less than 0.5 grams per deciliter, 12%, 13% of the patients. Renal impairment, creatinine of more than 2.5 milligram per deciliter, which is almost 14% of patients were excluded based on this criteria. Surprisingly, even a neutrophil count of less than 1.5 would exclude patients from enrolling into a clinical trial. And in this cohort of patients, 10% had this exclusion criteria. Even a hemoglobin of less than 8, which is very surprising for me, because many of the myeloma patients actually will have a hemoglobin of less than 8. And this have excluded about 10% of patients from enrolling into a clinical trial. Platelet count less than 75, 5%. ECOG about 2.6%. And finally, when you add up all the exclusion criteria, you end up with between 44 to 56% of patients being excluded from the clinical trial. So they divided the patients into those who are eligible for clinical trials versus those who are ineligible. And as you can see here, the red line is those who are eligible. And survival-wise, they were statistically better surviving patients than those who are ineligible for randomization to clinical trial, which is not surprising. So usually clinical trials end up having the best of the patients enrolled. Another survival, patients who had doublet treatment who are eligible did much better than those who are ineligible, had doublet treatment for myeloma. Those who had triplet treatment for myeloma in this cohort of patients also had a better survival compared to those who are ineligible. This article went into all the previous studies of real-world evidence for and data for myeloma patients, and tried to make sense and get some learning points and objectives. So lesson learned from real-world data versus clinical trial data. When you have 50% of your patient not represented in clinical trial data, then treatment decision must be tailored based on additional consideration beyond clinical trial efficacy and safety. So when you're seeing a patient in the clinic and they are not eligible for clinical trial, one has to look into treatment feasibility, tolerability, the quality of life of the patient after they have this treatment, and the impact on their comorbidities. There are multiple real-world multiple myeloma patients. They are usually symptomatic, very symptomatic patients compared to other hematological malignancies. They have treatment burdens, they have toxicities, their ability to participate in daily activities is reduced, they have financial issues. And one has to remember, although we are in a system which is luckily supports patients' treatment and the patients don't need to pay out of pocket any out of pocket cost for their therapies, but there is also still a financial burden on patients, especially those who don't live in the city where you practice. Those patients, if you have a protocol that requires them to be in the daycare for 2 days, 3 days, then that would mean that they'll have to come to the city where the treatment is going to be delivered. They have to find an accommodation, and they have to pay for the accommodation and the stay and the food they will use during their stay in that city. access to treatment and treatment centers, and convenience of treatment. So patient perspective. Patient's perspective is usually very important. It's the most relevant consideration, and the patients have different consideration that might be different from the physician, and they might have different goals of their treatment compared to the physician's goals. So we have to remember this. Physician perspective, physicians treating myeloma are faced with challenges of individualizing treatment choices. Now we are all about, individualized management of patients of all diseases. There are highly diverse patient populations seen across all treatment settings. Historically, the prognosis of myeloma meant that the patients usually survive around 3 years. However, now patients survive longer. And as you have a bigger pool of patients, then you will have more complex problems to deal with as a physician. And as you get more lines of therapy, highly active novel agents, then using those combinations is a challenge. To summarize, the treatment goals and treatment choices are therapy-related factors, patient-reported outcomes, and physician-related factors. Phase 3 studies are the gold standard and for any therapy because they are required by regulatory authorities for approving a medication. They have a strong internal validity. They have pre-specific and well-defined endpoints, and usually there is a randomization and blinding and control arms. And we have always to remember the saying that if you can't measure something, you can't improve it. So whatever we want to improve, we have to be able to measure. However, these phase 3 trials, prospective studies, they have limitations in terms of external validity and generalizability. Usually clinical trials are reported after a median follow-up of 1 to 2 years. So we don't know how many of the patients manage to continue having the medication that we are monitoring beyond the initial period. And this is a very important point that is different between real-world evidence and clinical trials. The full benefit might not be derived if drugs and regimens are not tolerable enough for real-world patients, which is 50% of our patients don't fit the eligibility of clinical trials in myeloma. If they impact the quality of life of the patient, especially the elderly, frail patients, available patients due to limited mobility or travel issues, preferences and affordability, again, might be an issue between real-world patients and clinical trials. And patient preferences, again, is something that is not looked at in clinical trials. So this slide summarizes the patient-related outcomes that and factors that will lead to treatment effectiveness, which is something that real-world evidence measures. So real-world evidence measures patient preferences, measures physical activity, work productivity, comorbidities, quality of life, disease symptoms, treatment-related toxicity, treatment convenience, and financial toxicity. So patient-reported outcomes, one should always keep an open mind setting when one is seeing a patient in the clinic. Because the goals of treatment differ between patient groups. Efficacy does not necessarily mean the same thing to different patients. Depending on the age of the patient and the comorbidities, efficacy might mean different things. So one has to take a holistic approach to dealing with these patients. Multiple myeloma patients have a great burden of symptoms. We all know the CRAB that affects myeloma patients, the hypercalcemia, the renal impairment, the anemia, the bone disease. In addition, they usually have fatigue, pain, gastrointestinal symptoms, neuropathic pain, and impaired quality of life compared to the general population. So patients might be more concerned with their symptoms rather than the efficacy of the treatment that we are going to deliver, and would the treatment that we're going to deliver make them more symptomatic than what they are now. So in clinical trials, you find that biochemical progression, patients are overrepresented. And this gives the group of patients in clinical trials a better quality of life measure compared to real world data. So this is a study in which patients' opinions were taken. Application 1 is the one that the most patients chose. Application 1 is a combination of treatment that is all oral treatment for myeloma. And you find that the majority of patients actually prefer this application, although they were told that the progression-free survival of this combination is less than its competitor. So they preferred, are willing to accept the lower progression-free survival time in an oral application mode than IV application mode. So this study is done by very eminent myeloma physicians. As you can see, the names of Richardson, St. Miguel, and Philip Moreau, and others. And what they did is translating the findings of clinical data into real-world setting. And in this study, they found that progression-free survival and time to next treatment values in real-world reports were actually shorter than those reported in phase 3 clinical studies. And longer duration of treatment has been associated with a prolonged progression-free survival, overall survival. So the better tolerated medications usually lead to better progression-free survival and overall survival. And you can see here injectable proteasome inhibitor was compared to oral proteasome inhibitor drug triplets. And in the phase 3 clinical studies, you can see that the progression-free survival was 18 months. The time to next treatment was 29 months. While when they looked at the same combination in the real-world reports, they found the actual progression-free survival was only 9.4 months, which is half what is reported in clinical trials. And the time to next treatment was 25 months, so it's similar to what we find in the clinical trial. While in the oral immune modulatory drug triplet, the progression-free survival was reported in clinical trial to be 17.5 months. Time to next treatment was 20 months. In the real-world data, the progression-free survival was slightly more, 19 months, and the time to next treatment, 27 months. So the data was equivalent to what the clinical trials have informed us. Why? Why is this difference between phase 3 trials and real-world data? They found out that 15 to 32% of patients actually discontinue medications in the US community oncology practice. Compared that to clinical trials, only 6 to 20% of patients discontinue medication. So there is a big difference between those discontinuing medications in clinical trials compared to real-world data. Pattern of relapse and progression. This is, again, trying to give examples of where registry data, real-world data is different from clinical trials. And this publication is looking at the progression-free survival of transplanted patients in Spain. And those who were transplanted in Spain, the progression-free survival post-autologous transplant was 3.3 years. While in the IFM study, which is a clinical trial, phase 3 trial, the actual progression-free survival of post-autologous bone marrow transplant was 50 months. So there is about a year and a bit difference between registry data in what autologous transplant gives you. And you can see here the data of the phase 3 trial by the French We move on to the patient choice. I will give an example of a 58-year-old gentleman, highly educated, works as a professional, diagnosed with myeloma 3 years back. Initially, when he was diagnosed, he had normal cytogenetics. He was treated with VRD 12 cycles. Initially, the plan, because of his age, is transplant eligible. We would have done an autologous transplant after 4 to 6 cycles of VRD. However, he refused an autologous transplant when he went into remission with his first treatment. And he kept in remission, was kept in remission with VRD 12 cycles for about 3 years. However, now he relapsed with a protein of 30 grams, and on relapse, he had a new cytogenetic abnormality, 1q amplification, which usually indicates a worse prognosis than normal cytogenetics, which he's had. My initial thought was he's young, he's fit, he would qualify for a second line according to the Pollux trial with DRD, which gave a median follow-up with a median progression-free survival of about 44.5 months, which is excellent, almost equivalent to having an autologous transplant progression-free survival. So these were my thoughts. DRD also is well tolerated and gives elderly patients a good progression-free survival compared to the comparator arm. Again, high-risk patients do well with DRD, so that's very encouraging. And again, those who only had one line and had DRD did extremely well, and at the time of publication, their median progression-free survival was not reached. However, the patient was made aware of these results and the benefits of these outcomes. The patient was not happy with coming to the hospital and not being able to work. And he said that his quality of life will be reduced, wants treatment that requires minimal hospital visits. And I failed to convince him of my opinion. So I had to resort to the tourmaline multiple myeloma study, which is between ixazomib lenalidomide dexamethasone versus lenalidomide dexamethasone. And this study has shown an improved progression-free survival of IRD versus RD. And in the real-world data of the Czech and Slovak registry, this progression-free survival held to be the same or better. IRD was, as you can see here, not reached compared to RD. Here, 23 months. So very good progression-free survival. Again, this is real-world data between Greek, Czech, and UK database. And again, the IRD has kept, as you see here, at second line of 27.6 months progression-free survival. So phase 3 data, real-world data, were encouraging with this combination. Patient received IRD 3 months of therapy. His back pain, which he had at relapse, has resolved. He's back to his normal life and daily activities, and his paraprotein has fallen from 30 to 1.2 grams. We move on to frail patients, and we as physicians, we always think that more is always better. Quadruplet treatments is better than triplet treatments, and triplet is better than doublets, and doublet is better than single agent. However, there is an impact of age and comorbidities in myeloma patients. And as you can see here, there is a second line initiation therapy. A significant proportion of patients have these problems, cardiovascular and renal impairment, in 27.7% of those having second line treatment. Cardiovascular only 8.8, and renal impairment in 31.4. And those who don't have renal or cardiovascular are only 1/3 of the patients. So comorbidities in patients having second line is significant. And as you can see here, those with comorbidities do statistically worse than those who don't have. Those who are above the age of 75, again, do worse than those who are below the age of 75. So we have to think of frail patients in a different way. This is an example whereby one has to consider carefully when dealing with frail patients. This upfront trial of elderly patients was in the US. It was comparing doublets versus triplets, and the median age of the patients was 73. 42% of patients were aged 75, 18% of patients were aged 80, and 73% of patients had the stage 2-3 myeloma. 50% of patients had comorbidities, 19% had a Charlson comorbidity index of 2. So quite frail group of patients. And in this group of patients, when they gave doublet, VD, and they compared to VTD and VMP, which we know usually do better than VD on its own. However, in this group of patients, frail patients, VD did as well as VTD and VMP in terms of progression-free survival and overall survival. So the progression-free survival was 15 months and 17 months. Overall survival was again equal between the three groups, telling us that in frail patients with comorbidities, maybe more is not always better than less. This is another trial where more is not always better. They compared dexamethasone 4 days, so 480 milligrams per cycle versus dexamethasone 160 milligrams per cycle. And you can see here the survival of patients who had a high dose was worse than those who had a low dose. And that's because those who had a high dose of dexamethasone had increased incidence of pneumonia, DVTs, a lot of side effects, early death. All were statistically significantly more in those who had high dexamethasone. In frail patients, again, the 2-year survival probability was statistically worse than those who had a smaller dose of dexamethasone. So again, we go back to real world outcomes and factors in this study. And this study looked at IRD in real world compared to KRD, compared to VRD, all real world data. And they looked at the event-free probability. And those who are fit did well with KRD, better than those who had IRD and VRD. However, those who had intermediate and frail patients, the IRD and VRD did statistically significantly better than those who received KRD. So it's important to think carefully when you're having frail patients. Many of these patients actually are not eligible for clinical trials, and maybe one extrapolate data from a phase 3 trial and apply it to a frail patient and leads to a worse prognosis of the patient. Renal impairment, as you can see here, is one of the major comorbidities of myeloma. We've seen this before, that in first line, patients might come in with only 12% with renal and cardiovascular. Second line, that increases. And again, renal impairment is a major. 1/3 of patients will have renal impairment of myeloma patients. Renal impairment, as in this slide, shows those who are less than 40 mL per minute have a worse overall survival than those who actually have a more than 40 mL per minute. And in this slide, again, it shows statistically significantly worse prognosis of renally impaired patients compared to those who don't have a renal impairment. And protocols that lead to an improvement in renal function lead to better overall survival, as we see in this slide. The International Myeloma Working Group has defined improvement in renal responses to treatment as complete response, partial response, and minor response. So those who have a creatinine clearance less than 50 and their creatinine clearance goes above to 60 or more is called complete response to treatment. Partial response is when they have a creatinine clearance less than 15 and it improves to 30 to 59. And minor responses is when they have a baseline eGFR of 15 and they improve to 15 to 29, or if they have 15 to 29, they improve to 30 to 60 mils per minute. So clinical trials eligibility tend to exclude patients with less than 30, and the reported rates of renal impairment in phase 3 trials between 7 to 20%, while in real life it is much more than that. Ixazomib IRD trials had 20% renally impaired patients. And as you can see here in the progression-free survival, less than 50 mils per minute were 92 patients. And there is a tendency to favor IRD as a treatment compared to the comparator in renally impaired patients. Daratumumab dexamethasone in this study was another agent that was seen to work with renally impaired patients. In this study, they had patients a median age of 72, 77% were male. The median time for diagnosis to first daratumumab dose was 4 years. Patients had 3 prior systemic therapies, 37%. eGFR at baseline was 13 mils per minute. And the 6 months progression-free survival was 50% using it. Ixazomib with pomalidomide again leads to complete and durable renal responses in more than 70% of patients. Itatuximab, carfilzomib, dexamethasone leads to complete and durable responses in about 52% of patients. So the way forward for clinical trials, there are ongoing initiatives aimed at modifying standard inclusion and exclusion criteria by removing comorbidity restrictions, which will improve the generalizability of trial findings. Similar initiatives are also required for defining inclusion criteria for real-world evidence studies analysis. So in conclusion, in our clinical treatment pathways and in our clinical daily practice, we ought to ask the question about patients in front of us. Will they be eligible to be included in clinical trial setting or not? If they are not, which is the 50% of patients who are not eligible, then this group of patients applying clinical data on them is not on its own optimal. One has to think about clinical trial data in addition to real-world evidence in helping us to improving our decision-making process. And with that, I finish my talk. Thank you very much for listening.
Thank you very much, Dr. Ihab. As usual, very nice and informative talk. I think it gives us so much insight about how to read and apply clinical trials, probably not in myeloma in particular, but in general, all of our oncology care patients whom there's always this major discrepancy between the type of patients enrolled in clinical trial and the type of patients that we treat in real life, this direct patient-to-patient physician relationship with all its implications. But in myeloma, probably it's a little more unique given the fact that there is so much comorbidities in those patients, and the complexity of the treatment regimens that are out there makes it sometimes difficult to be in the model of what one of my mentor previously used to say. It's a cookbook kind of practice. So it's not a formula that someone can take out of a cookbook, pull out of one of the regimens, and then just go ahead and apply it on his or her patient. And I think part of it is also one has to be consistent on what he does in his clinical practice. And one has to ask himself always, Why am I doing this? What's the reason and the logic and the mental logic behind my decision? On one hand, you don't want to be under treating somebody just to succumb for the progression of his disease. And on the other hand, you don't want to be over treating and causing more harm than benefit. Um, and if you would allow me, one thing that also confusing about many of the myeloma trials is always the choice of the comparator arm. Somehow there is a trend in all myeloma trials to use what we would expect from the start to be a less effective arm anyway. So there's always a problem with the comparator. You know, rarely you have those trials where you have a very good comparator arm comparing it with another arm and then asking truly the question of how the effectiveness is and what are the toxicities. Okay, so let's run to see what questions do we have. So we have a question from an anonymous attendee asking, would you rather use a treatment with a good RWE than another one despite its randomized clinical trial results are not as the randomized RWE results? I think RWE, he would refers to real world.
Thank you for this question. It's an excellent question. The point I was trying to make is that it's important to use phase 3 clinical trial data. It's the gold standard. We're not going to sway away from it, but we have to remember two important facts. Number one fact is that when you're using that trial to treat the patient, one has to think, would this patient be enrolled in that trial or not? If the answer is no, then in that case, using that clinical data will not be optimal to treat that patient. I might end up using that data in the end of that clinical trial, but I have to think and I have to make myself think, what would the real world evidence data suggest in that type of patient? So I would use the two together to make my decision. I would not use one of them. Mainly in those patients who actually will not qualify for that clinical trial specifically. However, if the patient qualifies for that trial, then I wouldn't have any problem using the clinical trial data. But if you remember that 50% of the myeloma patients will not qualify for a myeloma clinical trial, then there is a lot of patients out there who might be harmed by using a phase 3 clinical data trial and basing only that decision on treating them. I think one has to think wisely. I have given examples in frail patients, elderly patients. One has to think very wisely and think carefully about what treatments to give those patients based on real-world evidence and also clinical trials.
Yes, thank you. We don't have any other questions right now, but I mean, I see that you really didn't cover yet any clinical recommendation, which is good. I think it's your thought-provoking, and that's the most important thing. But let's just try to wrap it up. So in a transplant, I guess in a transplant eligible patients, things a little more clear, but in a transplant ineligible patient, so how would you approach that currently in Saudi Arabia? What would you do in your clinical practice? In upfront therapy, first of all, let's start with that.
In transplant ineligible patients?
Yes, transplant ineligible.
Obviously, as I said before, it's important that one has to think about this transplant ineligible patient, their age, their comorbidities, and what this talk and research I've done for this talk has made me think is one has to think whether this patient would be eligible to be enrolled into one of those transplant ineligible patients or not trials. If they are, then there is a lot of treatments out there that will be useful in this group of patients. One has also to think about the patient, where do they live, what's their wishes, and also involve them, if we can, into the decision-making process. So there are quite efficacious treatments out there for these type of patients. VRD is a treatment that is given as first line in transplant ineligible patients. DRD is another option in transplant ineligible patients with excellent results reported in the Maya trial. It's well-tolerated combination. However, there is always a price to pay with these triplet combinations. How often the patients need to come to the hospital, admissions. So one has to balance these against the efficacy of these protocols. It's something that one can't make a clear. I don't think one can make a clear guidance in this is the only therapy I would use. I think I would use an NCCN type guideline, whereby I say my preferred option is this, but I have a second and maybe third option to use in special circumstances.
Yeah. Would you still use a doublet for any patients, or you're still?
Yes. Yes, there are patients who are very frail, and it's very hard for them to come to the hospital, as you know, for these weekly injections. So you can use lenalidomide, dexamethasone.
So for the doublets, if you have because if the patient still can, if I think it's the matter of the patient can come to the hospital or can't, not rather than the issue of comorbidities, right? Because if the patient can come to the hospital, then adding an antibody, most likely daratumumab, would make sense in those patients, unless the patient is really very sick from other reasons. But then if we are talking about the oral regimen, so you would still use Lendex in those patients up front, or would you prefer a proteasome inhibitor in that scenario, if you're going with an upfront therapy, with or without an antibody, let's say?
Obviously, the data for IRD in first line. There was a meaningful progression-free survival benefit for IRD, but it wasn't statistically significantly better than RD. So this is where the difficulty is in first line with a proteasome inhibitor. It is very convenient, and I think it is very likely that it will give us a better progression-free survival and maybe a reasonable side effect profile. However, in second line, it's approved and it has shown statistically significant benefit compared to RD. So I wouldn't have any problem in real world evidence and data to use IRD as a second line treatment for patients for its convenience and for its side effect profile and its efficacy as well.
So what's your stand also on the issue of MRD negativity? I mean, we all know the data with KRD, with or without transplant, regardless of the patient's transplant eligible or not. And, being one of the highest regimens achieving MRD negativity before or after transplantation was with KRD upfront therapy. So, what's your take on that? Or would you rather saving the carfilzomib to a second line therapy, or would you rather start with it and then save the daratumumab for second line? And then, the fear of the issue of neuropathy, and I'm preferring to start with carfilzomib rather than bortezomib in those patient population. So, what's your feel on neuropathy as a main, if you let's say, concern for patients, and how much does it affect your decision in choosing the regimen as well? So, two questions here: the MRD, if you're actually, or the depth of response in general. And the other issue is the issue of neuropathy, and how much does it weigh on your choice of therapy?
Okay, for the MRD, obviously MRD has always been linked to a better overall progression-free survival, overall survival, if it is achieved. There are some people who argue that those who achieve an MRD negative have got different biology disease than those who are MRD positive, which is probably the case. However, the argument against that is if you have a protocol that gives you more MRD negativity than other protocol, then you would expect that this will lead to a better progression-free survival, overall survival compared to the other one. So extrapolating data. So MRD is still not in the clinical practice, so it's important that still it's a research tool. However, phase 3 trials with MRD, looking at MRD, are being reported. And obviously, patients who are fit and can receive intense protocols then can be used in these patients. However, the peripheral neuropathy is an issue with some, but not all patients. And our first line protocol is VRD. And I think what future holds is a quadruplet in young fit patients. Using daratumumab with VRD is something that is showing very, very promising results, and it's well tolerated. So I think the future is probably in quadruplets rather than triplets, in my opinion.
Thank you very much. Yeah. And then if you would allow me one last point, I think some people also, many of us actually are sometimes sinful in forgetting, which is the role of supportive therapies in the multiple myeloma patients. We tend to concentrate more on the therapies of the disease, and sometimes we forget about the supportive therapies, which do have an effect on the quality of life the patients may have. And that's we've seen it always in our clinical practice. That's a point that's overlooked sometimes. All right, I guess we don't have any other questions. Any last thoughts, Dr. Ihab, before we close?
No, I would like to thank the SSBMT for giving us this opportunity and having this discussion. I'd like to thank the sponsor, Takeda, for their sponsoring this session. And I wish everyone a good night.
Indeed, yes. Thank you very much. And I was just to announce something on behalf of the SSBMT that please be informed that those who have attended at least 50% of the SSBMT webinar series will be granted 10 CME hours for the year 2021. The CME hours will be credited by the end of December 2021. However, we decided to submit the attendees by the end of November 2021. Also, please be informed that upon submission of attendees list, it is still the discretion of the Saudi Commission whom will grant the CME hours to. So that's regarding the CME. I also want to bring to your attention the next webinar series of the SSBMT on Saturday, the 4th of December, from 8:30 to 9:30 p.m. KSA time. This talk is going to be titled Invasive Fungal Infections Update in Hematology Setting, and it will be given by Dr. Juan Martinez, who's an associate professor of hematology, Department of Hematology, University Hospital of Gustafsberg in Belgium, Department of Microbiology, Immunology, Transplantation. And I think it will be moderated by Dr. Marwan Shaheen, who's a consultant section of adult hematology, stem cell transplant and cellular therapy, King Faisal Specialist Hospital and Research Center in Riyadh. So try to make it to the talk. It's very interesting and important for us who treat leukemia patients and BMT patients. With this, I would like to bring this meeting to a closure. Thank you all for attending, and please have a good night. Stay safe, stay healthy, and hope to see you all soon. Good night to all. Thank you very much.